Good evening, and I'm so glad that you could join us this evening for a very special webinar. We've been working on this project for a while now, and we think it's truly worthwhile for our kidney cancer patient community and even outside of our kidney cancer community because it has just really good basic information as well. I'd like to introduce our speaker this evening. It is Dr. Anand Swaminath. He is, welcome Anand, thank you for joining us. He is a clinician scientist and radiation oncologist at the Hamilton Health Sciences Centre and the Juravinski Cancer Centre in Hamilton, Ontario. His clinical research interests are the application of new technologies in radiation therapy, specifically stereotactic body radiation, for a wide variety of indications, including kidney, lung, liver, but particular interest in kidney cancer. He is also an esteemed member of the International Radiation Oncology Consortium of Kidney Group and the Canadian Kidney Cancer Information System, which is CKIS, which we are a partner with. And he's on the steering committee. And he is also, thank you, a medical advisory board for Kidney Cancer Canada. He is a co-principal investigator on several local and national trials, including SBRT in both the primary and metastatic RCC setting. So he is the perfect specialist to be speaking to you tonight about SBRT. He's going to do a little introduction to our brand new education resource, which we are so grateful for, and he is the author of. So I'll let you take it away, and then we'll look forward to your presentation following. Thank you.
Thanks so much, Christine. I really appreciate being invited to come and speak here, and also, of course, to be involved in the creation of this patient guideline for those who are going through SBRT, or those who may be referred for SBRT but don't have, may not have the knowledge of understanding what actually they've been referred for. So it's great to know have this forum to present these present this new guide. So we're going to first we're going to show you online the guidelines. So this is and we'll put a link in the chat that takes you directly to this PDF. So this is the educational guideline that we have put together on SBRT, a patient resource. And again, a tireless number of hours spent both on the front end with myself writing this document, but more importantly on the back end with support from Kidney Cancer Canada to make this look very pretty and also make it applicable and friendly for patients and their caregivers. And so some of the content that's inside this guideline will sort of define what is SBRT, how SBRT may be relevant for you in terms of treatment of localized kidney cancer and for metastatic kidney cancer, and some instances where maybe SBRT is not being recommended and why that may be the case, and what sort of things you should expect during the SBRT process. So this is just the beginning of the guide, talking to patients and their caregivers, just intended for those who have kidney cancer, who with localized disease, or with metastatic kidney cancer, where either your surgeon or oncologist feels that radiation therapy may be an option for you. And as we go through this, and just showing you a bit of the highlights of this guide, I have a presentation that's going to elaborate a bit more on some of these points, so we can speak to that as well during this presentation. Do we want to go to the slides now? Great. So this is just my introduction slide, so to the next. So what are our goals for today? So the first goal is to understand what is SBRT, and is it different than other forms of radiation therapy? And then if I have a cancer that's localized to the kidney, is SBRT the right thing for me? Next is, what if my kidney cancer is spread somewhere else, having metastatic disease? And is there a role for SBRT for me then? And what situations may that be the case? And then I think importantly, and one of the things that we don't see a lot in patient resource educational resources are, what is the SBRT process and what am I to expect going? And to touch a little bit upon what may be the side effects that I may experience. And finally, what are some realistic expectations about how well SBRT works? And as we go through this, we'll keep going back and forth between my presentation, but also some snippets from the guide, from the educational guide, so that you can understand some of the questions that you may want to ask when you're going through the SBRT process or SBRT and want to understand a little bit more information about how it may apply to you specifically. So moving forward. So the first question is, what is SBRT? So first of all, it's important to understand acronyms. So some doctors call it SBRT, and some doctors actually call it SAVE. And depending on where you live and which cancer center you can go to, you may receive both of those acronyms in your clinical encounter. They both mean the same thing. So SBRT is a form of external beam radiation. So that's X-ray therapy. So X-ray therapy is external treatment. It's kind of like you lie on a bed and you get an X-ray. And typically when you get an X-ray, X-rays are designed for imaging. So chest X-ray or abdominal X-ray. But external beam radiation uses high energy X-rays. Those X-rays are designed to kill cancer cells. So the goal of SBRT in particular is to give a very high dose of radiation to a cancer in a single or few, typically 5 or less total sessions. So you may know of some individuals, friends or family, who have had radiation. Typically, radiation is given over several weeks. You're getting a little bit of radiation every day over a total amount of days, which can equal 6 to 7 weeks sometimes. But kidney cancer cells don't respond to these traditional radiation recipes. Actually, if you look under the microscope, they're actually very resistant to these traditional radiation recipes. And so we have to ramp up the amount of radiation we're able to give every day in order for us to have effectiveness against kidney cancer cells. In particular, a lot of work has been done in terms of preclinical, meaning in the laboratory, to prove this. And then now we're seeing it in the clinical space as well. So it's really important to understand that SBRT is a form of radiation that allows you to deliver a high dose of radiation in a few number of treatments. And this is described very nicely in the patient resource in terms of what radiation therapy is, how it's delivered, and who your team will be. So a radiation oncologist like myself is a cancer specialist who will determine whether or not radiation treatment is useful for you. But your radiation team goes beyond me. So there are many people involved, including nurses, radiation therapists. So radiation therapists are specially trained to actually administer the radiation. So I don't turn up. So a lot of patients will ask me, so are you there when I get my radiation? The answer is typically I'm not there. It's usually done by the radiation therapists. And a specific form of radiation therapist is a dosimetrist, and they help map out the radiation. So we do specialized radiation mapping, and we'll talk about this towards the end when we're describing how people will experience their SBRT in terms of what the dosimetrists do. And then medical physicists are, again, very highly specialized PhD trained individuals who work behind the scenes, not only to ensure that the radiation being delivered is safe, but it's being delivered with high quality. So there's a lot of people who will be on your radiation therapy team. And I just tend to be the first person, but I'm certainly not going to be the only person. So when we're looking at SBRT for localized kidney cancer, this is a situation where you have a tumor in your kidney, and it's felt that perhaps surgery, which is the standard of care for localized kidney cancer, may be too risky, or you may just not want to have it for whatever reason. And it also means that your doctors may want to explore non-surgical options. So some questions that I think is important to ask when you go into your appointment is, well, why is radiation good for me? How is it different from other treatments? Are there particular aspects of my cancer that make radiation a good option for me? Is it effective in controlling or curing the cancer? How does it work? Will it disappear like after surgery? What are some of the short and long-term side effects of my radiation? And how will it affect particularly the health of my kidneys? Because we are treating the kidney, and so radiation will damage potentially part of the kidney as well as trying to control the cancer. So moving forward, so let's talk a little bit about SBRT for localized kidney cancer. So like I said before, the current standard of care is surgery for localized kidney cancer that has not spread beyond the kidney. However, there are several patients who may decline surgery or who are unfit, either because they have medical problems, they're unable to have surgery because of their poor fitness or exercise tolerance or age. And in some cases, SBRT can be considered as a non-invasive alternative option. And like I said before, SBRT is given using X-ray treatment. These don't penetrate. They're not, they penetrate through you, but they don't actually cause any sort of damage like surgery does in terms of like a pinprick or a poke or anything like that. There's no scars that you see on your skin. And it's usually done as an outpatient procedure, whereas with surgery, you have to be admitted and observed for 3 days after. So, SBRT may be preferable to other non-surgical approaches. So some people may have experienced thermal ablation, called RFA or radio frequency ablation, which is heating up the tumor, or cryotherapy, which is freezing the tumor, both of which are alternatives to surgery. They're done using imaging, like a CT or an ultrasound, along with a needle that has a probe on it that either heats up the tumor or heats out the tumor. And then some people may even have their kidney cancer watched for some time, so surveillance. They may not necessarily need any treatment right away, particularly if that tumor is small and not growing very fast. And there are other things that you have to worry about to your medical health, where the kidney cancer may be a less priority area at that time. So what are some instances where radiation may be a reasonable option? So the first is tumor size. So once a tumor gets to 4 centimeters in particular or bigger, these non-invasive options like thermal ablation or surveillance become less effective. Or if the tumor is sitting next to something that's critical. So I've used this diagram just to illustrate. Here, there's a hollow tube, and that could be your stomach, that could be your large bowel, it could be small bowel, it could be an airway, something like that, where it may be risky to do a surgery or an ablation or a type of ablation using heat and cooling. Or the location within the kidney itself. So if it's very central within the sort of center part of the kidney as opposed to the periphery of the kidney, that may be more high risk for a non-surgical approach. So we're talking about, in this situation, patients who are not eligible for surgery. When can we consider SBRT? So what do we know about SBRT as an effective treatment? So it's actually quite effective. There's been a number of important studies that have been performed in the last few years showing a very high effectiveness. So this is what the group that Christine was alluding to. This is the International Radiation Oncology Consortium Committee, and I was a part of this. And we showed that with SBRT, kidney cancer control is very, very good. We have 95% chance that patients who are treated will not have their kidney cancer recur. And only a small proportion of patients have kidney cancer will come back. And very similar to the types of numbers that we see with surgery. And what's interesting about this study is that we treated people with larger tumors. So these were tumors that were on average 4 centimeters. And those are the types of patients that we tend to see with SBRT, who may have not had a good option for their treatment of kidney cancer in the past because surgery was not an option. And this is a very large study that came out of Australia that actually just got updated about a month ago that showed, again, similar control and survival rates for kidney cancer. So radiation can be a very effective, and SBRT is a very effective treatment. However, what's important to understand is that there's been no direct head-to-head comparisons of SBRT versus its other treatments. So when we discuss the options, I think it's important from a shared decision-making perspective that we don't hang our hat on one thing. It's important to hear the pros and the cons of all these different types of treatments so that you can understand which one you think is best. So what are the short and long-term side effects of kidney SBRT? It's very well tolerated in general. Most people do not have many side effects, and the rate of having a severe long-term side effect that would require either hospitalization, surgery, or something along those lines is less than 3%. But the commonest side effects are you'll feel tired during it. You'll also feel maybe a little bit nauseous, and that's commonly treated with some pills that we would give for nausea that people usually take about a half an hour to an hour before their treatment, and then they can take those pills subsequently. People might get some irritation of their bowels, maybe get some diarrhea, and also irritation of the bladder. They get some frequent urination. But those types of side effects typically fall off within about a week or two after the radiation is done. And like I said before, this is a short treatment. It's only done over 5 days. Typically, the treatments are done every alternate. So it gives you a bit of time of a break in between each treatment, and allows your body to recover a little bit more. And within a week or two after those treatments are done, some side effects. And long-term side effects of kidney SBRT, well, there's a very low risk of causing a leak or a ulcer that can damage the bowel and lead to a complication that requires surgery. It's a very rare occurrence. Unfortunately, I have seen some patients that have had that recurrence, and I'm very upfront when I talk to my patients that this can happen, and there's nothing that's going to prevent it from happening. There are some things that we can do to help, at least in our mind, alleviate to some degree the risk, but sometimes people are just more sensitive to radiation. We do whatever we can when we map out the radiation to ensure that the doses that are going beyond the kidney to these organs that are sensitive are as low as we possibly can. And then there's a very, very low risk of having your kidney function go down to such a degree that you'll need to go on dialysis. And usually going on dialysis is more a function of your overall kidney function than it is because of any one treatment. So as you can see here in this curve is slowly going down, 5 up to 5 years post SBRT. And it's a decline, but it's not a significant enough decline that it's going to cause a problem. And this is a really cool diagram I like to show. I even like showing this diagram. But this shows your kidney. So the black actually represents how much activity, let's say, for instance, is in your kidney. So you can see here, this is before someone had SBRT, and they have very black kidneys here and very black kidneys. That's a good thing. That means your kidneys are functioning really nice. And then you can see the radiation mapping on top of it. And as time goes on, you can start seeing that the black here becomes white, where the radiation map is sitting up. So we know that in the affected kidney that we're radiating, we are reducing the function of its somewhat. But what you can appreciate here, and what's interesting, is it actually becomes more black. It's hard to see in this, but it becomes more black in the other kidney. So we actually know that the other kidney, and I tell people this all the time, is you have 2 kidneys, so one will pick up the slack. And that's what tends to happen, is the other kidney picks up the slack. And so your kidney function doesn't go down significantly because the other kidneys pick up the slack. And in a situation where you may have had a nephrectomy and you have only 1 kidney left, and then you're asking the question, well, what's going to happen to me now? We actually see that the unaffected kidney becomes more black as well. So your body does a great job of trying to compensate for whatever damage has been done by working harder, unbeknownst to you, to help improve your function. So that's why the rate of dialysis is so. So here's a little example of a patient of mine with localized kidney cancer. This is a 72 man. He had heart failure, he had a previous triple bypass. Unfortunately, wasn't unable to have surgery. But they found a renal mass on his workup in 2015. And he was actually put on an active surveillance program. So he actually didn't have any treatment for some time. They felt because of his other comorbidities, it was difficult, or other sort of medical conditions, it was difficult to know what his prognosis would be. So they said, let's just watch the kidney cancer because we're more worried about his heart. And the patient agreed. So they watched it for some time, but it continued to grow, and the patient was actually doing okay 4 years later. And so he wound up having a larger mass at around 5.5 centimeters. This is a CT scan of his abdomen. And so this is the kidney here on the right. So right is left and left is right when you're looking at CT scans. This is his kidney here on the right, and this is other kidney here on the left. And that's his liver sitting in front. So that's the tumor that's sitting in his kidney. And it grew to 5.5 centimeters. And the surgeon felt that this is a bit too big now to just continue to launch. And so they sent them to me because the patient was not eligible for thermal ablation because the tumor was bigger than 4 centimeters. And the patient was not a candidate for surgery because of the scar tissue. So they asked me, can I give SBRT? So I said, well, let's go ahead and try. So this patient had SBRT, and this is just the radiation dose map. So the green represents here the tumor. The blue represents a bit of a safety margin around the tumor that we use to account for things like, we'll talk about this later, how you breathe, how your bowels moving, that sort of thing. And then the red here represents the high dose of radiation. And what I like to tell patients is radiation is kind of like throwing a puck in the pond. You see a big splash with a high dose here, and then you see a ripple effect where these radiation dose lines, which are in these different fancy colors, drop off really rapidly. So that things like your bowel, which is sitting right here, you can see that tube right there, that is part of the stomach. The end part of the stomach is receiving a very low dose of radiation. So that's how we map out these treatments. And then the patient went on for follow-up after his radiation. And we followed him for several years. So this is December 2016. You can see that mass in the kidney again. It's roughly the same size. And then if you go to January 2019, again, roughly the same size. So the tumor never went away, but it never grew either. And the cancer never spread. So what we think happened is that the cancer was, these cancer cells were probably dormant. We killed off most of them, and the rest of them sitting in here were probably dormant and not actively dividing because the patient didn't develop any further cancer growth. Unfortunately, they passed away because of unrelated issues complicated by COVID. And so on. But they did very well from the kidney cancer. So the question of it never shrank away. So what are the expectations after SBRT to primary kidney? Well, it may take a long time before the tumor shrinks. But that does not mean that the radiation can come back. And so how do we know this? Well, we've done some studies where we've taken biopsies of the kidney, and then we've looked at those cancer cells under the microscope. And we've done some special tests on these cancer cells to see, well, what are they actually doing? The answer is they're actually asleep. They're dormant. So what I tell my patients is that we put these cancers to sleep, and they are very unlikely to wake up 4 or 5 years down the road. And eventually the cancer cells will die off, resorb into your system, and the tumor will eventually shrink. But the expectation is that they probably won't go. And this applies to both localized and when I'm going to get into metastatic disease, the same thing. That sometimes patients wonder, how come the tumor hasn't disappeared? And I'm like, it's not that it hasn't disappeared, it just hasn't. It's not actively growing. So that's actually a good thing, and that's a realistic expectation. So how do you know if SBRT is right for you? So it's important to ask some important questions. So how big is my kidney tumor? Where is my kidney tumor located? Am I fit for surgery? Because again, surgery is still the standard of care. And I think it's important that you see a surgeon first to understand your option of CV or one of my colleagues. And if I had surgery, how much of the kidney will you need to remove? How will I feel and how will my body and kidneys function after surgery or ablation using thermal ablation? So it's also important to realize that there are multiple options. The best choice will be for you and your particular circumstances. So I encourage you, if you're in this situation, to go back to your referring physician or your urologist or your oncologist and ask them some questions. And so within the guide, we've actually put those questions in as well. So that's something. So shifting gears a little bit, we'll talk about metastatic kidney cancer. So you may be consulted by a radiation oncologist because you have metastatic kidney cancer. And so people with metastatic kidney cancer are typically on systemic therapy. So either on immunotherapy or oral therapy, or sometimes patients are on active surveillance, which means they're just watching the cancer. Or you've been on therapy for a long time, you've had a great response, they've stopped the therapy, and you're in this what we call treatment-free interval, where they're just watching things, they're seeing how things are going from scan to scan, and making sure that the cancer is not kind of doing anything that would be misbehaving. And so there's many reasons to give radiation in metastatic disease, but using SBRT in particular, with a high dose treatment and with the goal of killing off the kidney cancer cells. So there's a couple of indications. One is called oligometastases, and the other one is called oligodeletion. So I'm going to define these. I'm going to just go through, past this and just define these. So what is oligometastatic? So oligometastatic is, if you break out the word, oligo means short, and metastatic means metastatic. It's cancer spread. So short cancer spread. So typically this is a scenario where a patient has metastatic disease, but it's only in a few areas, typically 5 or less areas. So if you look at it schematically, this is a patient and they have let's say they've had a nephrectomy for their kidney cancer 6 years ago, and now they've developed a lesion in the lung, a lesion in the spleen, and a lesion in the lymph node. And they biopsy one of those and it shows that the cancer was returned. But it's only returned in one of these 3 spots. There is a scenario where you could consider, instead of starting systemic therapy, which is the standard of care for metastatic kidney cancer, there are some situations where you can consider a local therapy for this. So could we eradicate those tumors using local treatment and maybe not require systemic? In the setting of oligoprogression, again, breaking up the word, oligo short, progression means progression. So the cancer has progressed. So you could be on systemic therapy, or you could be on active surveillance after having received systemic therapy previously. And instead of having a few spots that they're watching, there may be several spots that they're watching, but only a few, 5 or less again, are growing. So this is kind of a scenario where it's a bit different, right? So this is more of a earlier scenario. This could be a bit later on in the game where you have systemic therapy already on board. So this is a bit of a different trajectory when you're looking at your cancer journey with respect to what the options for treatment may be. But the use of SBRT would be very similar, and technically would be very similar in both of these circumstances. Just the intent is different. So what could we potentially do? Well, we could potentially treat, and using our SBRT high dose radiation to treat these 3 spots in the oligometastatic setting, and then you may not necessarily need systemic therapy. But in the oligoprogressive setting, you may have this situation where I like to kind of think of it as weeds in a garden. So you have the weed man coming, spraying the garden for any weeds that you may not see that may be creeping below the surface. But every once in a while, you have a weed that grows out of proportion, and that is oligoprogression. So what I usually tell my patients is, I'm the weed whacker, or I'm the guy that's going to pull out that weed and use my muscle and allow 2 reasons for doing this is, hey, this is not as well controlled with the systemic therapy because it's growing despite it. So we can give a local therapy to try and kill off those resistant cancer cells. But not only that, we can help make that spray or systemic therapy work better. So we're not sort of, this, it's not this situation where all the systemic therapy is going to try and kill this one, big tumor, when all these little tumors are not seeing the effect of it. If we can eradicate this, then it tells your body, hey, I can go and treat those other ones now more effectively. And maybe this one, I don't need to do as much on because it's already been treated with some more. So that's kind of the mentality behind it and rationale behind it. So lots of questions for you to ask when it comes to metastatic disease. So the first question would be, obviously, how many metastases do I have? And how many of these are growing? Because you could have, metastatic disease, but nothing is growing, and you may not need this therapy, right? Or you could have had systemic therapy and be on a treatment-free interval and not require SBRT. Conversely, you could be on systemic therapy and have 3 metastases and say, hey, is there a role for SBRT? I only have 3 spots. I mean, I'd like to get better cancer control. Could I potentially see a radiation oncologist to discuss this? So these are some things you can think of. Where are these lesions and how big are they is important. So we talked a little bit about size, and that 4 centimeter size, and often for metastases, typically 5 to 6 centimeters is what most clinicians would use. But I'm of the mindset that it depends on where they are as opposed to how big they are, whether or not SBRT can be safe. How long have they been there? So, how long has my cancer journey been? What systemic therapy have I been on before? Were they there before and now they've grown back? Or are these new spots that weren't there before? So that's an important question. How do I need to start or change my systemic therapy because they are growing? And I think that's the most important question to ask, especially if you're already on systemic therapy. If I can get this treated with SBRT, what are we going to do about my systemic? Should I just stay on it? Should I switch it? Like, what is the goal? And if I get SBRT now, will I not be allowed to start or change my systemic therapy later? And again, those questions kind of go hand. Can I get SBRT more than once in the same area? We can talk about that. I'll have a bit of a talk about that later on. If SBRT works but the cancer grows again, can I get SBRT again? Talk about that. Again, similar sort of question. What are the side effects? And does it depend on where the lesion you are treating is in the body? And then finally, is SBRT supposed to cure my cancer? And what is the goal? And so we're going to go through a lot of these things in the next few slides. And that's from the educational systems. So here's an example that I like to give. So this is a 69-year-old female, metastatic kidney cancer on targeted therapy. So they're on a second-line treatment, crizotinib. They did not do well on first-line immunotherapy, and this was October 2019. So a couple of years after they started their crizotinib, they're actually doing well on it. They have multiple metastases, but only this one here, circle in the abdominal wall on the left, is growing. So they were referred to me to ask the question, can we give SBRT? My answer was, this seems like a reasonable thing to do. So let's try. So we gave this person SBRT, so zapped it. And then a few months later, we repeated the scan and they actually had a very good response. So like I said before, this is not an expected response. Most people will have stable or better disease. To have a complete response, this tumor is gone, was actually quite surprising for me to see, meaning that it was very responsive to radiation. But unfortunately, on the same scan, a new lymph node popped up in the center part of their chest. So this is someone's chest CT, and this is their right lung, this is their left lung, and these are the blood vessels in the middle part of your chest, and there's a lymph node sitting here in the sternum. So unfortunately, this patient developed a new spot, but it was the only spot. So then I got asked again by the medical oncologist, can you do another round of SBRT and we'll keep them on crizotinib for now? And I said, well, it's not anywhere near what I treated before, so let's try. So I did this, zap this one. Then we move forward to a year later almost, where you can see that this is well controlled with the SBRT, that sort of lymph node that was enlarged is now down to a normal size. And this spot here in the left abdominal wall remains well controlled. But unfortunately, this patient developed further disease in their chest, in their lungs, and lungs. However, they were very grateful because they were given an extra year on the same. If they did not receive the SBRT, they may have had to switch to lymphodepletion. So it can be effective for oligometastatic and oligoprogressive disease. On average, it's important not to hang your hat on this because your chances may be better or worse than this. What I usually tell my patients is if you're in a situation where we're treating either oligometastatic or oligoprogressive disease, the time before you either have your cancer progress or require a change or start in a systemic therapy regimen would be roughly the time it takes the earth to grow, which is about a year. So that is not a hang your hat answer, but it's a good guide. But your chances may be better or worse. However, if your cancer progresses, can you get SBRT again, right? So this is in general. So your cancer may progress in one spot. It may not progress in multiple areas. And so there may be an opportunity to do more SBRT. And this depends on many factors. The location of this new the recurrent or the new lesion relative to the previous SBRT, how many spots or lesions have progressed, how well you are, obviously, you have to be fit. And I always tell patients, the more radiation that you get, it's kind of like systemic therapy. As you get more and more systemic therapy, you get cumulative additive side effects. So the same thing with radiation. The more and more courses you go through radiation, the more and more that fatigue might get in. So you might have to think about that, right? How much do I want to go through this even? And then how long have you been on your current therapy? Well, if you just switched your therapy and it's been a month since your CT scan and it's grown, I might just come back and say, well, let's see how well this therapy is working for you. I don't think we necessarily need to treat right away. If the therapy actually works, I've had a couple of scenarios recently where we didn't have to do SBRT because the therapy started working. And so there's really no rush in doing it unless there is an indication that we feel like, wait a second, this may be not as helpful as we think it should have. But I like to preach patience as well in my opinion, when we're dealing with this scenario, because we don't want to overcommit to using SBRT every single time. And so what is the data on SBRT? So it's effective for treating metastases. And the control rates and the side effect rates are very, very similar. But the survival is varying because, again, everybody comes in with a little bit of a different story in terms of their metastatic disease. So some may have had 3 lines of systemic therapy. Someone may just be newly diagnosed with metastatic disease. So the intent and the outcomes might be slightly different, but the effectiveness of SBRT in treating those metastases is roughly the same. And if you look at patients who have had oligometastatic renal cell carcinoma, so that scenario we first talked about, where they might have had a nephrectomy and they only have 1 or 2 spots that have shown up after their nephrectomy and biopsy that showed they didn't have metastatic cancer. If you do radiation or any form of local therapy up front, or in this case SBRT, you can see that some studies have shown that 2/3 of patients may never even require systemic therapy. And so there are certain scenarios where we will think about doing SBRT as an initial treatment, as opposed to systemic therapy, so that we can save the tools in our toolbox that the medical oncologists have that are so effective these days until later. And I think patients appreciate that as an option if it's feasible to us. And then if you're already on systemic therapy and your cancer progresses, we also have data that supports giving SBRT in oligoprogression. And the longer that you're on systemic therapy, the more likely you are to benefit. So that's why that whole concept of preaching patience is really important, because I like to see patients have a good response to their systemic therapy. If they're not responding well to their systemic therapy, that means it's highly unlikely that the radiation is going to give them an extended length of time to respond further to their systemic. So, I don't want to be rushed in giving SBRT if it's not necessary to do so, particularly in the first few months of a new drug. We want to give it time to work before we decide, listen, this is a good idea. So how do you know if you're a candidate for SBRT for metastatic disease? So similar to types of questions we kind of went through before, but how long was it before my cancer spread? How many metastases do I have? Where are these lesions? How big are they? And if I go on systemic therapy now, can I get SBRT later? And if I get SBRT now, that may be ineligible for systemic therapy. So these are all in the educational resource for you to remind yourself of this info. But these are collaborative decisions. So your radiation oncologist and your medical oncologist should work together to better understand your situation, how these questions will be answered. And when I talk to my oncology colleagues who treat kidney cancer, we say the same thing. These are multidisciplinary decisions. These are decisions that are made in silos, and we don't want to do something that will compromise what our colleagues are thinking about doing down the road. So we have to be collaborative in these decisions. So, when you meet with your oncology team, it's important to ask these questions, but understand that the decision is a collaborative and not done in a rushed way. So what are the side effects of SBRT when you have metastatic disease and we're treating for oligometastatic or oligoprogressive disease? Unfortunately, this would be a I could do a whole talk on SBRT side effects because it depends on what we're treating. So if we're treating the lung, it's different than if we're treating something in the abdomen. It's different if we're treating something in the pelvis. And so if it's done safely, SBRT, as we discussed in the localized setting, has a very low risk of long-term severe, let's say severe, side effects in general. But if repeat SBRT is needed, so that question that was posed before on, well, will I need SBRT? Can I get SBRT again? Or if it's in a close proximity to what we've treated before, the side effects will largely depend on the overlap with the previously treated areas. And so the radiation oncologist will decide if it's too risky to treat. And I think just because it's, there's a referral for you to see a radiation oncologist, those decisions on whether or not it's safe to do, particularly if this is your second or third time seeing a radiation oncologist for SBRT, those considerations have to be made. And sometimes, it can be disappointing to hear that no radiation can be offered, even if it's a single spot. It's like, oh, can't you just treat this one spot? Like everything else is great, but if it's already been in an area that's been treated before, it can be riskier to do so. And so important to have that conversation. So what are my realistic expectations post-SBRT in metastatic kidney cancer? So I think I want to emphasize, and I think most people have good insight into this when they come and see me for a consultation, because they've already seen a medical oncologist and they're already on systemic therapy. So they understand that the overall goal for our treatments is generally not to treat. However, good control of disease is possible. And in certain situations, we can prolong and delay progression or need to switch the systemic therapy with SBRT. And in some cases, I have seen a delay that lasted forever. So it's not impossible, but it's not our expectation. So when we first go in and we have a discussion, I think understanding realistically what our goal is important. Because if the goal is cure, then I think you have to be cautiously optimistic about that goal when it comes to SBRT in metastatic cancer. What I usually tell patients is SBRT is very good at controlling the spot we're going to see, but it's a spot that I can't see. It's that weed, right? So this weed spray, but we can't see. That's maybe growing, and it's just under the soil. We don't know it's popped up yet. So the biggest risk may be the cancer showing up somewhere else. And that is more often the case when we see progression in all the studies that we've done. It's unlikely to be that spot that's been treated. It's another area. And so when you're making these decisions, it's important to understand the balance between, well, life expectancy or quantity of life versus quality of life. And all these considerations need to be made when deciding on whether or not that's appropriate. Okay, so what if my doctor's not recommending SBRT? What's the like? I'm sort of promoting this like this is like the one thing that everyone should have, but there's actually scenarios where no, we can't do it, right? And there's many reasons why it may not be optimal. So you have metastatic disease, and there's something that's very acute that's happening. So you have severe bone pain or something that's causing bleeding, and we need to give radiation in a more urgent manner. And that is not necessarily something we can do with SBRT. So we would give a more palliative or traditional course of radiation. There may be too many metastases, and in which case systemic therapy may be better for you than giving SBRT to the numerous spots that we see. And sometimes a CT scan can underreport the degree of metastatic spread. So reviewing your CT scans with your oncologist and saying, understanding like, I know a lot of patients now get access to their CT scans. And so they're like, oh, there are 2 spots. But the oncologist looks at it is like, actually, no, they're just giving you an example. So, I think from understanding what your reports say as well, to ask those questions to oncologists, how many metastases? There might be 2 of them. They might be in very high risk locations where they've had previous radiation or SBRT, and those cases. And your oncologist can talk to you about those specific images. And then how come, well, if I have a kidney cancer that's present and I have metastatic disease, why aren't you treating my kidney cancer? And so that's um, you know, a scenario where you may not offer SBRT as well, because the kidney cancer where it's all started may not be well controlled. And so the role of SBRT in some of these scenarios are still under investigation until we have better clinical data to guide us. These are largely individualized decisions. Okay, so that's just the same thing in the educational resource. All right, so this is kind of the final piece to this. So what do I expect undergoing SBRT? So let's just say your doctor has recommended you have metastatic disease, you're on immunotherapy, and there is a spot in your lung that is growing. And you see a radiation oncologist say, okay, yes, I think this is a good treatment. You've been on this for a year. You're doing really, really well. You've had a good response, but this one lung lesion is growing. Let's treat this. Okay. So the first step would be we would obviously agree together that radiation is the right thing for you, sign a consent form, and then we book the radiation mapping, which would entail a few things. So you get a specialized CT scan to help mark out the area to be radiated. Okay, and that's usually done in the cancer center. So it's not done in the radiology department, it's done in the cancer center. You'll typically be lying flat on your back, more often than not with your arms raised above your head. It's kind of like when you go for CT scans. You may or may not need to lie in a device to keep your body still or wear a special mask or frame. With SBRT, our real goal is precision and accuracy. As I talked about before, that's what our medical physicists are helping us achieve. In order for us to do that, we need the patients to be as still as possible. So we put them in this, what we call, it's called a stereotactic frame or a body. And depending on the site and your kidney function, the doctor may decide to give contrast or IV dye to better see the tumor. Sometimes we can give IV dye if you've had an nephrectomy and your kidney function is not as great. We'll have a conversation about whether it's okay to give you the dye. Sometimes we get away without doing dye. There may be special tools used if the area being treated moves due to breathing. So you can imagine in this case, if this lung spot is being treated, let's say, we might have to limit how much the tumor moves when you breathe. So we do what's called a four-dimensional CT, which is that picture in the middle. So it's not just a static picture of your chest. We can actually track how much the tumor is moving as you're breathing. And not only that, some special tools can actually limit the motion by using a device that compresses on your belly. It's basically called an abdominal compression device. Or the radiation unit can actually turn on and off during specific phases of your breathing cycle. So if you're breathing in and we can see the tumor, it will turn on. Then you're breathing out, it turns off. You're breathing in, it turns off, and so on and so forth. So there are special tools that we can use if the treated area is moving. And that's very common in kidney cancer because a lot of the metastases that we see are typically in moving areas. The liver, the lung, the kidney itself moves, the pancreas moves, and we see those tumors quite frequently that we have to treat. So these tools are important to use. What happens after all of that's done? So once the scans are done, you go home, the radiation therapist, before you go home, the radiation therapist put little small tattoos on your skin. And that's the only invasive thing that happens with SBRT. So you get these little tiny pinprick and a small tattoo that's the size of a freckle to help them ensure that they're targeting the right area for treatment. And then your CT scan images get transferred to a special radiation software that the oncologist and the team I talked about, the planners, those dosimetrists use to plan your treatment. So this is what a radiation plan looks like. It's during this process where we define where the tumor is, what dose to give, and how much radiation will be acceptable to the organs thereby. So you can see here, this is a kidney on the left. This is the tumor here that you can see that red radiation dose line around. And this is the bowel in front of it. So we outline the bowel, we outline the tumor, we outline the kidney, and depending on the region that we're treating, we're going to outline the areas that we think we're most concerned about that radiation may spill into. So we do all of this. It's kind of like adult coloring, but for a radiation oncologist, it's really important that we're accurate about where we're targeting. And then the planners put together these very, very highly focused pinpoint radiation plans so that we're just treating that tumor and the radiation that's going to the bowel is as minimal as possible. So this is what we spend most of our time doing in the back end that you may not necessarily see, but this is probably the most vital part of treatment. So once the radiation plan is approved, it goes through a number of quality checks and a test to ensure it's physically doable on the radiation treatment units. That happens even before you come in. We actually test everything. We make sure the machine won't collide with the bed. We make sure that the beam angles are all deliverable, that the radiation fields are sufficiently large enough that you're going to get your treatment without causing a complication. And then the treatment starts. So if these are important things for you to understand. So if you're on any oral systemic therapy, like zitinib, levitin, nibatinib, zopanib, whatever, anything that ends in ID, you usually will stop this drug 3 to 5 days before the SBRT to ensure there's no overlap of treatments that could worsen the side effects. If you're on immunotherapy, this usually isn't held because we have safety data showing it's safe to do SBRT with immunotherapy, and it takes much longer for immunotherapy to clear out of the system. Depending on the area that we're treating, you may or may not require some medications beforehand. Let's say we're treating something that's close to your stomach. You might have to take medication to help with that nausea. If it's close to some other vital structure, we might have to give you another type of medication to help alleviate it. So there are some medications that we give prior to that your doctor will talk about. Each radiation session typically lasts about 15 to 20 minutes. It could be longer if you're treating multiple areas. You'll be set up in the same position as you did during that first mapping or simulations. Before the radiation turns on, a mini CT scan or an X-ray will be done to ensure that the target is being hit accurately. So we do a little scan, then we move you, and we reposition. We do another scan if necessary. We want to make sure, again, we want to be accurate and precise. So we do those scans to ensure that we are in the right position. Then the radiation turns on. It typically moves fast in the arc or a number of different beam angles around you and finishes less than a few minutes. So most of the time is spent setting you up, making sure we're hitting the right area, and the radiation's only on for a couple of minutes. You then go home and then you come back for the remainder of your sessions. So this is just a little diagram of how things kind of look inside a radiation unit. And this is that mini CT scan that I talked about before. It's not as nice as a regular CT scan. You can see it's kind of grainy, but we can make out, for the most part, where the tumor is, which is in green here, and where the kidney is here. And this is just a kidney cancer that we're treating. But in the lung, we could make out the lung, and where the tumor is, we can make out where the pancreas, and where the tumor is, and similarly in other sites of the body as well. So these scans are used to help us align the patient to the treatment, and then we start the treatment as we're happy to do. And these are important questions to ask your radiation oncologist as you embark on treatment. So will you see, what will you see, will I see you, during the radiation treatment, and how often? Should I see or feel anything during the actual treatment? Typically not. Some people have mentioned to me that they see stuff or feel like this presence of aura, but these are silent, these are invisible activities. So you shouldn't see or feel anything. You won't become radioactive. And I always tell people, unless we're treating an area where there's hair, you won't have any air loss. So that's kind of the first three things I tell folks. If I'm on targeted therapy, do I need to stop this? And we talked about that. What if I'm immunotherapy? We talked about that. And then we talked a little bit about taking medications before or after the treatment. Are there any precautions I should take? So some oncologists will ask you to do certain things, maybe not to eat 3 hours before. Some will ask you to take a bowel prep, depending on where the location of the tumor is. The precautions might be slightly different. Eating and drinking, it's at your discretion typically, but there might be, like I said, not eating before, that you can have a normal diet prior to that sort of 3-hour window before radiation. Can you tell if the radiation's working during the treatment? Why or why not? And usually we can't, because our scans, as you see, they're pretty crude. They don't really give you good anatomic information about tumor response. Sometimes we will have to adjust the radiation plan if we see something dramatic. And we have seen that from time to time, where the tumor has grown because of swelling from the radiation, or the tumor has shrunk because it's responded really well. But those are usually the exceptions and not the rule. Can I change the radiation dosage if I'm having side effects? Why or why not? Typically, our radiation plan is set out so that you get the same amount of radiation every day. There are times where we might have to stop early, or we might have to delay it if you're having side effects, but we try to finish the course as, equivalent amount per day as possible. If it's been delayed for way too long, we might have to replan the radiation. But our intent is to still give the same amount of radiation the day before. we may adjust the dose in that circumstance if it's been a really long time, like a month or something, you're hospitalized for something else, and then you have to come back and finish your radiation. We may have to adjust the dose a little bit to account for that delay, but for the most part, we try to give you the equivalent amount over those 5 days. So once SBRT is completed, depending on the intention of the SBRT, follow-up routines are going to vary. So these general questions, and this is within the resource, will provide you direction on how your care should be. So who will follow? So if it's a localized kidney cancer and you've been referred to see a radiation oncologist, typically that's the radiation oncologist. If it's metastatic kidney cancer, that's typically the medical oncology team in conjunction with the radiation oncologist as a sort of consult or FYI type of situation. And we usually see our patients on an as-needed basis after the event. Will you receive regular scans? Typically, the answer is yes. Most patients who have SBRT will get regular scans afterwards, whether it's localized or metastatic. And for sure, if you're seeing your medical oncologist, you're going to get regular scans as well. And can I continue my previous systemic therapy? And we talked a bit about that in terms of when to stop and when we started. And then how long should I continue the medications you gave me? And that's important as well, because some medications you only take during the SBRT, and some medications the doctor will say you need to take them 3 to 6 months afterwards, just to ensure that we've done whatever we can to reduce any long-term side effects. So depending on the drug, that answer will be good. When will I know the treatment has been effective? Again, we talked about this. Sometimes the radiation works, but you don't see it objectively on a CT scan. The tumor doesn't disappear. If it gets smaller, that's great. If it remains the same size, that's great as well. So our expectation is stable or better. Complete response would be amazing, but stable or better is what I usually aim for in my patients getting SBRT. But again, that doesn't mean it didn't work. It just means those cancer cells have fallen. And then what is the expectation following SBRT? And we talked about that, I think, in terms of both localized and metastatic disease. So, there are several options that may be available to you if the cancer doesn't, or if the radiation doesn't work, or the cancer goes somewhere else. And again, those decisions have to be done collaboratively with the radiation oncologist and the medical oncologist overseeing it. And I think that is the end of my presentation. So I hope I've clarified a lot of these points. We've used the educational resource to sort of highlight some of these more important things, particularly with respect to the questions that you should carry in your back pocket when you come to an appointment with a radiation oncologist. And with that, I'm just going to hand it back to Christine, and I want to thank you for your time.
My goodness, don't disappear. I have a couple questions, but what a detailed presentation. I can't thank you enough. I think I don't see any questions in the chat or Q&A because I think you explained everything so clearly and in patient-friendly language. So sincerely appreciate it. Thank you, Dr. Swaminath. There was just a couple things I wanted to elaborate on, and because there was so much information, we might have missed it. You were talking in the beginning about treating small tumors, active, like non-metastatic. Is SBRT, I know there's like cryoablation, radiofrequency ablation. Is SBRT becoming a treatment of choice for small renal masses?
So it actually depends on where you live in. So
yes,
if you live in Australia and you have a small renal mass, the treatment of choice is SBRT. But if you live in America, it's still probably thermal ablation at this point. But I think there is a growing interest in using SBRT for those who either may not be, even those who may be eligible for a thermal ablation procedure. Our urologists are now explaining all options to patients. Because I think from a decision-making perspective, you have to understand what the pros and cons are of each of those therapies. Some patients are good with having an ablation, but when they understand what the procedure entails, they don't want anything invasive. Then they kind of gravitate more towards SBRT. Whereas those who, may not know their options, then they're not informed, and they're going with what their, surgeon has told them is the best for them. So
of course.
I think from a decision-making standpoint, having all options on the table, and it's interesting when we present cases now at our meetings. One of our urologists, who's also a Kidney Cancer Canada.
Yes.
He always explains we should present all options on the table to our patient, let them decide what they think. So
But
the
it's great.
culture is changing, but yeah, it does depend on what you.
Okay, and that kind of leads to my next question, but that SBRT, would you consider it to be as effective as the ablations?
So I think we have some data that, again, there's never been a head-to-head comparison
Hmm.
between SBRT and these other therapies, surgery or thermal ablation. We have
Hmm.
some what we call randomized comparisons. So these are comparisons done using studies or using patient cohorts that have not been randomized. So again, when you're dealing with that, there is an element of bias in that where you might be favoring one group or another. And so taking that with a grain of salt,
Right,
there's not much of a difference between the two. So radiation, SBRT, and thermal ablation tend to have similar
right.
outcomes in terms of controlling the cancer and survival. So, we're hopeful that in the future
Yes,
we could do a formal head-to-head comparison between the two. And that's, not to toot my own horn, that's something that I'm working on.
right. That would be actually very good, and that was my next question. Are there any clinical trials regarding SBRT right now?
So in localized kidney cancer, there's actually in Canada, there's nothing that's kind of on
Mhm,
open, but I think
mhm,
there are a number of interested parties that are working towards a large comparative trial of SBRT versus thermal ablation. For
mhm.
metastatic kidney cancer, we just closed a randomized trial, but there are other ones that are going to open, probably
Okay.
looking at oligometastatic kidney cancer and oligoprogressive kidney cancer, mainly out of the US. So as Canadians, we can kind of jump on board with those studies. In Europe, they're actually doing a randomized trial of SBRT versus surgery um, for localized kidney cancer, which is quite an accomplishment. That's probably the peak of the
Absolutely.
spectrum there in terms of like what you can do with this in terms of comparative studies. I see a
I
question.
would I'd be definitely interested in learning more about that option,
Yeah,
that comparison. Um,
that
we
trial's on.
will Oh, really? Okay. We will certainly keep our eyes open, and I'm sure that thank you. You usually keep in touch with us when clinical trials are approaching or when something might be of interest. So I appreciate that, and we'll keep our patients informed if something comes forward that they
Absolutely.
may be able to participate in. You kind of
Absolutely.
touched on, and I see there's a question from the attendees. Is SBRT only available at larger cancer centers, or is it becoming more and more available across Canada?
Yeah, it's becoming more and more available across Canada. I would say that certain centers don't do certain types of like certain specific sites, but kidney SBRT, there was a trial at Sunnybrook
Yes.
where centers who hadn't really started an SBRT program were able to kind of jump on board. So there's been a lot of interest in joining that just to get their program started. And I think as
Hmm.
a result of that, a lot of centers are now interested in doing this. There's a huge sort of push to want to do more kidney SBRT. For metastatic disease, SBRT is pretty commonplace for most sites. So for lung tumors, for spine tumors, for liver tumors, typically SBRT can be given in most cancer centers. Now, if that's
Okay.
not the case, there's usually a understanding between a smaller and a larger cancer center. So
Mhm.
this is what I've learned actually over the past couple of months. I attended the Canadian Cancer Trials. What I learned from that was if a center can't give SBRT, they actually have like kind of a, for lack of a better word, big brother center that does
Yes.
that treatment. So if a patient is eligible for it, they can go there. And so in our region, in Hamilton, there are certain things that our colleagues down the road in Niagara can do, like
Yes.
for SBRT and some kidney, and they come to me. So we
Okay.
have that understanding, yeah, between smaller and bigger centers. So if it's not available at a smaller site, you can reach out
Mhm.
and say, well, if I get referred to a larger site, if I live in, you know, a smaller place, but there's a large cancer center an hour or so away, is there a possibility that I can get referred there? And I've had some patients referred from out of province for this
Yes.
treatment, but I've actually educated them into ensuring they can do that in their province now. So obviously we want care as close to home as possible. And as the years go on, SBRT will become more and more widely utilized. I'm pretty sure about it.
Okay. That was also another referral that I had. And actually, I know there's someone watching today that actually had to leave their home province and go to another province in order to have their SBRT treatment. So,
Yeah.
it's difficult, and that's something we at Kidney Cancer Canada advocate for all the time is care at home. Like
Yeah.
you should have access to care for what you need in your own province. But unfortunately, that doesn't always work that way. So we really appreciate our medical advisory board and our healthcare professionals who really help promote, and advance this practice.
Just to speak to that point, I think it's really um, vital for us to understand where those gaps are happening.
Mm-hmm.
Because if we know, then we can educate or we can align, right? So if you're living in Saskatchewan and they're not offering SBRT there, because this is what happened to me. I had a patient from
Mm-hmm.
Saskatchewan up to Hamilton. I'm like, can't you go to Winnipeg? Can't you go to Alberta? Is there
Mm-hmm.
an option for you there? Like at least not having to fly over two provinces to or one province to get to me, right? Like so I I'm all for the advocacy piece in terms of ensuring that those messages get sent out. So if there is, there is sort of gaps in care across the country, I'm happy to. And I have had reach out from Manitoba, had reach out from the East Coast that have started their programs and are kind of talking to me. So I know that people are interested in doing this. Sometimes
Mm-hmm.
it's a little bit of a lag, right, between
Mm-hmm.
the evidence and then the adoption of that evidence. And so
Right.
I think that we're starting to see such great results with kidney SBRT and for
Mm-hmm.
metastatic disease that the lag will be shorter and shorter and more people will get on board. But until then, if there is someone that's struggling because they can't receive their SBRT close to home and they have to travel, I think that's an important piece for us, as an MAB and from KCC to advocate for care closer to home as best as we can.
I agree. I agree. And actually, I will send you a follow-up email with that information so that you can have some insight, and maybe you can help us um, go forward with this advocacy campaign. Because it's very important. And I don't see any other questions in the chat. I think you've done such a wonderful job of explaining it in detail. And I'll just let everybody know that if you did miss some pieces of information this evening, or you'd like to do a little more detailed study on this webinar will be living on our website and our YouTube channel. We just need to do a little editing first, but it will be on our website so you can review it again and again and get your questions answered. And once again, Dr. Swaminath, I can't thank you enough for your time and effort and expertise in authoring this very valuable education resource, and for coming tonight and sharing that information with us. It's really very much appreciated. So thank you.
You're very
And
welcome. I just want to
I
say
wish
one
everyone. Yes, please. Yeah.
more thing. Sorry, I know it's
No.
overtime. I just want to say one more
No.
thing. I think from just understanding this information, this is for you to take back home with you and speak to your own care team about these
No.
questions. We're here to provide support for you as best as we can, but ultimately we want your care to be as we want to try to coordinate our care as much as possible across this country. So
Right.
if there are gaps, and we try to identify them. But at the end of the day, this resource is meant for you so that you can take it back to your own care team and make sure that those questions are dutifully answered. So that's my
Well,
last.
well said. And actually, in that point, if you are experiencing difficulty um, achieving that goal of having SBRT, or there's some challenges that you're facing at home or in your home province, please email us at info@kidneycancercanada.ca, or just visit our website. It's info@kidneycancercanada.ca, or you have the phone number there. Please call us and let us know, because we can't advocate for you if we don't have that information. So we're here to help. So if you need help, please contact us. And then we have our medical advisory board that can help us too. So thank you so much for joining us this evening, Dr. Swaminath. All the best to you. And we'll see you at the next webinar. And don't forget, June is World Kidney Cancer Day month. We celebrate all month, and there's lots of activities and emails that will be coming your way. I hope you'll participate and pay attention to this valuable message from World Kidney Cancer Day. Thank you again. Have a good night.